Yeah. All right. Good afternoon, everyone, and thank you for joining us for today's seminar presentation. Today, we have Dr. Prachi Singh joining us from Pennington Biomedical Research Center in Baton Rouge, where she serves as an associate professor. Dr. Singh is also the director of the Sleep and Cardiometabolic Health Laboratory at Pennington, as well as a collaborator with Mayo Clinic Cardiovascular Medicine. She's currently building a sleep-centered translational research program at Pennington, where her lab aims to conduct comprehensive, long-term behavioral and drug-based interventional clinical trials. Dr. Singh is primarily interested in obesity and obesity-related disorders, with a particular focus on the mechanistic roles of adipose tissue, sleep, and sleep disorders in the development of hypertension, insulin resistance, and cardiovascular disease. The title of her presentation today is Fat Talks, Location Matters. Please join me in welcoming Dr. Singh.
Hi, everyone. I'm Prachi. As Dusty mentioned, I am at Pennington Biomedical. We are just getting started here. And so let me begin by first minimizing myself on the slides. Okay, so here we are. Today I'm going to talk about fat talks and the location matters. To get started, let me briefly give you an outline of my talk. What I'm trying to do is provide answers to 4 main questions. The first being, what is obesity and why does it? The second is all fat equal? Third, what causes visceral fat increases? And lastly, what can we do to be healthy? So let's get started with the first one and try and define what obesity is. So obesity can be defined as a condition associated with high body weight for a given height. This directly leads from the index used to determine adiposity or obesity. And the most commonly recognized obesity is when you have a BMI of 30 or more. Now, this definition has a problem. And the problem is this. If you look at these 2 images, both might have technically the same body mass index, but the individual on the left is not a person you would call obese. So a more precise definition of obesity would be that it is a condition characterized by an excessive accumulation and storage of fat in the body. So now that we have defined what obesity is really about, let's think about why it is a problem. Well, obesity is a problem because it is epidemic. Next, I'm going to click and show you some maps showing how the obesity epidemic has progressed over the years. This map here is from the year 1995, where each state is depicted by a color based on the prevalence of population with obesity. All the states here are blue, indicating that all of them had a prevalence of obesity of 19 or less. Let's jump 5 years ahead now. Look at this map from 2000. Few of the states have started to see an increase in the obese population. These are depicted in different shades of red or orange. I don't know how you'll say that. Let's jump forward next. You see that the number of states which were blue have really drastically reduced, and more populous states are becoming deeper red. Going forward, 2009, there was one single state which remained blue. 1 year forward, and all the states in USA are now all shades of red. Now, looking at these increasing obesity rates, you do think, is there anything that is keeping pace with this obesity epidemic? Perhaps the US death. Even though the death may be a tad bit ahead, the obesity rates are really giving it a fierce competition. So much so that obesity could be considered the state of America. With a population of 115 million, and which is getting bigger day by day. So much so that the population is estimated to double every 20 years. Now, important thing is that obesity is not just a US problem, but it is a global concern. Now, this is an old cartoon and things may not be much accurate, but the things are not accurate not because obesity has lost weight, but because there are more concerns pressing for the pandemic right now. Now, why is increasing obesity population a problem? Well, it is a problem because obesity is not a standalone disease. It is a precursor to many other chronic conditions and diseases. And importantly, it takes toll both physically and mentally. Let's look at some of the facts related to obesity. High BMI is considered to be an exacerbating factor in more than 20 diseases. Second, 90% of the people with type 2 diabetes are overweight or are living with obesity. Obesity is also directly linked to heart disease, cancer, hypertension, sleep apnea, and osteoarthritis. Lastly, even with the current COVID pandemic, obesity has had a deadly or a drastic effect. Among the US adults hospitalized with COVID, 78% were overweight or had obesity. So there should be an easy fix, right? Get people to be not obese and you solve a very big problem. But things are not so simple. Obesity is very complicated. It is more than just willpower to stop eating or exercising. It has to do a lot with genetics, the socioeconomics, and the environment. The place obesity is a place where 1 in 3 adolescents live in neighborhoods that don't support physical activity, where 42 million people can't afford nutritious food. The cost of healthy living has increased more than wages over the past 10 years. And where 1 in 3 ads offer junk food. How are you going to solve the obesity problem in this kind of environment? So, in other words, obesity is not what you eat, but what is being fed. What is it that you gather from your environment which makes you eat what you eat? Now, obesity is such a big problem, but let me tell you what we are trying to do about it in our lab. Well, we are trying to answer 3 basic questions. First is how obesity alters cardiometabolic risk. What we are trying to figure out is what are the molecular mechanisms in the physiology behind increased risk in an obese individual. The second question we are trying to figure out is what makes a person obese. We all know that increased calorie intake makes the person obese, right? But what is it that makes a person eat more or make poor nutritional choices? Because if we can understand that, maybe we can prevent that from happening. The last is how to overcome obesity and related cardiometabolic dysfunction. So here we are trying to figure out what kind of interventions may be needed to make an obese person healthy. So this again is pretty broad, and more specifically, what we are doing in our lab is we are looking at adipose tissue, sleep, and sleep disorders, and trying to see how all these three fit together with obesity and cardiometabolic dysfunctions. So let me quickly summarize the take home from this section. 1, obesity means having higher adiposity or fat. It has not just something to do with your body weight, because you could be normal body weight, but if you have high adiposity or higher fat mass, you are actually obese. Second, I want you to remember that the obesity prevalence is high and it is increasing. Lastly, obesity increases the risk for several diseases. And if you're scanning the multitude of bows linked to obesity, you can't help but think that getting fat does more than make you sick. It may actually speed up the aging process. In other words, it's like an accelerated aging program you are in, which you don't want to be in, right? So now this brings me to the second part of my talk, which is all fat equal? I just told you that having high amount of body fat is not good for your health. So if I want to answer this question in short, the answer would be no. The long answer would be that it depends upon what are you looking at, or what, if being fat, what matters. There are 3 things that we need to consider about. The first one is the quantity of fat. So when we're talking about quantity in an obese person, it means you have too much fat compared to other tissue types in the body. But it is also important to know that too little fat is also not good for you, and it can also cause cardiovascular and metabolic problems, as in the case of lipodystrophies. The second aspect is the quality of fat. When we talk about the quality of fat, we are talking about the cellular and the molecular composition of the fat tissue, such that we want to make sure that the fat is able to do its job. The tissue does its job. It is able to store fat when excess calorie is around, and it is able to provide energy when there are energy deficits. The last but not least important part of the fat is the location. Where in your body do you actually store your fat? And this is the main topic or the focus of my talk today. So we all store fat differently. Some of us store fat in the abdominal region, commonly referred to as the apple shape. And some of us store fat in the lower body, on your hips and thighs. That is mostly commonly referred to as the pear shape. Now, what it does is that this also confers different levels of cardiovascular risk. If you have the apple-shaped body or apple-shaped fat distribution, you have a higher risk of developing cardiovascular and metabolic diseases. On the other hand, if you store your fat in the lower body, then it is actually providing protection against cardiovascular and metabolic diseases. Now, this is important. And the way we figured out this, it has been through a lot of cross-sectional studies, which showed that different kind of body composition gives you a different kind of risk. But I would like to draw your attention to a study which we did, where we showed that the central fat is associated with increased cardiovascular mortality, even in normal weight individuals. What we did here in this study was that we looked at the database that NHANES created from 1988 to 94. That was the time when they were actually obtaining the waist and the hip measurements in the study participants. And we classified central obesity based on the waist to hip ratio. So a higher waist to hip ratio meant that the person was centrally obese. We had different cutoffs for men and women. And based on the measures that we obtained, we classified them as normal or we classified them as normal waist to hip ratio or high waist to hip ratio. High waist to hip ratio meaning having central obesity. These individuals were followed up for 14 years or so, and we looked at their cardiovascular mortality. And what we found was that even in people who had normal weight, individuals who had a higher waist to hip ratio and were centrally obese, the risk for developing of dying because of cardiovascular causes were very high. And in other words, if you are normal weight or you were obese, the presence of excess abdominal fat conferred almost a similar increase in the risk of cardiovascular mortality. Now, to understand this more, I would want you to look at this figure here, where you have individuals who are normal weight. Now, compare this to the graphs over here, where you have obese individuals who were classified based on their waist to hip ratios. And the risk that we are seeing, the hazard ratios, which is depicted up here, is almost similar. So it does not matter how obese or if you have normal weight. If you have central obesity, the risk of you developing cardiovascular diseases and actually dying from cardiovascular causes is very high. Now, an important take home here is that these are associations, right? These kind of studies do not demonstrate causality, but we are interested in trying to find the mechanisms underlying, right? So what we did was we tried to gather some experimental evidence, and we did a longitudinal model of weight gain, where individuals were actually screened and randomized to either weight maintenance or weight gain, and then they were followed up after 8 weeks of this intervention. Inclusion exclusion criteria was pretty basic. We just wanted to make sure that the participants were healthy and they were not obese, because it would be unethical to have them gain more weight if they were already obese. And the study measures that we were interested in were related to the regional body composition. So we did whole body DEXA and supplemented that with abdominal CT images. We were also interested in the cardiovascular outcomes. So we looked at the vascular function and the ambulatory blood pressure. The way the weight gain was done was through overfeeding. Participants were asked to follow their regular dietary choices. They ate their food at home. But what we did was we provided them 1 to 3 supplements, such as the shakes, chocolate bars, Boost energy drinks, so that they were able to gain approximately 5% of their body weight in the 8-week period. If they were gaining too fast, we cut back on the number of supplements. If they were gaining too slow, we added the supplements. And at the end of the 8 weeks, we did the follow-up measurements. So what happened with our intervention is what we had designed it to be. In the first 2 columns here is the data from the weight gainers. The weight overfeeding led to an increase in body weight, approximately 4 kgs of weight gain. And these increases in body weight were mainly related to increases in total body fat mass, while the fat-free mass did not really change. And our weight maintainers did a good job of not gaining any weight or changing any of their body composition measures. So in terms of regional fat distribution, what we found that the overfeeding caused maximum gain in the upper body subcutaneous fat mass. This was followed by increases in the lower body fat mass, and least was the visceral fat mass. So this was in line with what the thinking is in the field, that the upper body subcutaneous fat is the first to respond to both excess calorie conditions and during energy deficits. So that is what we see in our participants. Now, lower body fat is considered a sink for long-term fat storage, and it is considered to be a very safe place to store, because these are the studies which have shown that if you store fat there, it's protected, right? The last, visceral fat, is considered to be an ectopic fat depot. And the most important thing to know about this fat depot is that it's known to be able to have a spillover effect, and any kind of fat being stored there is not really safe because the conditions there is not very conducive. So what happens to the vascular function? Now, to measure the vascular function, what we did was we looked at the ability of the brachial artery to dilate in response to cuff-mediated occlusion of blood, right? So for a healthy, you would want the change to be very robust. If you cannot have a lot of change, that tells you that there is a vascular dysfunction happening. So let me show you what happened in our study subjects. Here in the red is the data from our weight gainers, and in the blue are the data from our weight maintainers. On the y-axis, we have plotted the changes in the brachial artery diameter. And what we found that during weight gain, or after the weight gain, the changes in the brachial artery diameter had reduced, suggesting that there was a vascular dysfunction happening. Now, while in our weight maintenance group here, there was no change happening at all. So they were good. Whatever was happening was because of the weight gain. There was no temporal effects as such. We saw a similar thing happening with blood pressure. In weight gain, these are the data from in yellow, and the data from weight maintainers is in orange. We see that there was an increases in the systolic blood pressure, the mean arterial blood pressure, and the pulse pressure only in the gainers. And also, there were no changes in the 24-hour diastolic blood pressure or the heart rate, or changes in the office blood pressure. So the weight gain, even a modest amount of weight gain, had detrimental effect on cardiovascular system, as shown by the vascular dysfunction and increases in blood pressure. So our next question was, what increases cardiovascular risk during the modest weight gain that we had caused in these study participants? Our first thing we did was we looked at all the traditional risk factors associated. These were the lipid levels, the adipokines, the inflammation markers, or even the glucose metabolism, if there were any changes happening. And to our dismay, we found that there was no correlation at all. So none of these factors were really making a difference when it came to, say, vascular dysfunction. So next, what we did was we examined the relationship between the risk factors and the changes in regional fat depots to see if that is something which is more important. And indeed, what we found was that increases in visceral fat were the main factor which was elevating the cardiovascular risk. I want to look at this graph over here. So if you were an individual who had gained a lot of visceral fat, the amount of dysfunction you saw was huge. And if you had less of a visceral fat gain, there wasn't really much happening. This suggested that increases in visceral fat were the main factor responsible for the cardiovascular risk. This was further confirmed when we looked at the correlations or the relationship with the blood pressure. What we found was that the change in the mean arterial pressure during the weight gain was correlated pretty decently with the changes in the abdominal visceral fat. So this suggested that visceral fat is the one which confers the highest cardiovascular risk. So again, let me summarize what I try to tell you in this section, which is that all fat is not equal. 2, the location of the fat is important in determining cardiovascular risk. And 3, among all fat depots, visceral fat confers heightened cardiovascular risk. Okay. Now, let me go back to the third question in the outline now, which is what causes visceral fat increase, right? It would be $1 million question. So if you knew that, you could solve a lot of problems related to obesity. Now, to understand that, let's go back and think about the apple and the pear shape, right? What is important is that there are real sex differences when you talk about the regional fat distribution. An obese man is more likely to be an apple shaped, and an obese woman is more likely to be a pear shaped. Importantly, after menopause, women too tend to become more of an apple shape. So what this is telling us is that it is possible that the sex hormones play an important role in determining where you store your body fat and the whole body fat distribution. So at the same time, when we were thinking about all of this, there was this elegant study published in New England Journal of Medicine. And briefly, what they did in the study was they had healthy men come in. They suppressed the endogenous testosterone. As a result, there was also suppression of estrogen. And once everything was suppressed, they started providing testosterone supplements. And in some cases, they ensured that the estrogen was still not produced by providing aromatase inhibitors. And so there was 2 groups where you had men with different levels of testosterone, and then you had men who had testosterone but had no estrogen. The main finding of this study was that the decrease in estrogen because of the study protocol was associated with increases in abdominal subcutaneous fat. And this suggested that the estrogen might be really important. So we said, okay, let's go back to our weight gain study and see if the decreases in estrogen were associated with visceral fat gain during the overfeeding. So we had to restrict this portion of the study or the analysis only to men because we had not controlled for the menstrual cycle in women or the female participants in our study. And what we found was that testosterone or any of the estrogens did not change with a modest weight gain. But what did change was SHBG. SHBG is the sex hormone binding globulin, which binds to all these sex hormones and determines as to how much of it would be available for any action at the cellular level. Now, these decreases in SHBG did translate to probably lower levels or statistically significant increases in testosterone and estrogens. So we went back and saw what was happening, and we realized that neither changes in estrogen per se or the estrogen SHBG ratio correlated with any changes in any fat depot. So we were kind of a little disappointed that our theory or our hypothesis is not what is happening, right? But what we did see was that the baseline E2-SHBG ratio associated with the changes in visceral fat. So let me walk you through this slide. On the left here, you have the changes in total body fat mass. On the x-axis, we have the E2-SHBG ratio. These are what the levels were at the baseline prior to overfeeding. And we find that the baseline levels of bioavailable estrogens correlated very well with the changes in total body fat mass, which is shown in the A graph. In this B graph, we have the changes in upper body fat. So there seems to be a good correlation even with that. Now, when we dissect out the upper body fat as subcutaneous versus visceral, we find that the correlation, there was a good tendency for correlation with the visceral fat mass, but not so much with the upper body fat mass, the subcutaneous tissues. So this suggested that the higher levels of bioavailable estrogens may protect from upper body fat accumulation during overfeeding induced modest weight gains in healthy males. So estrogens might still be very important because they might be the one which will stop you from gaining fat in the wrong place during energy excess conditions, right? But this is not something which can help you develop an intervention so that you take a pill and you lose your visceral fat. So that part was still missing. And we were still trying to figure out if there can be interventions and what other factors cause visceral fat changes. And we tried to think a lot. And honestly, we really do not know if there are factors which preferentially cause visceral fat gain. But the answer may be partly related to sleep. And the reason we say that it may be partly related to sleep is because there is a close connection between sleep and cardiometabolic health. So if you have poor sleep, the chances that you are obese or have high blood pressure or diabetes are quite high. And when we talk about poor sleep, we are talking about three factors. The first being the sleep duration. If you are if you have short sleep or a small sleep duration less than 7 hours, it can cause problems. The second is we're talking about the sleep timing. It's like, what time do you really sleep? Is it that your sleep aligns with the natural day and night cycle, or it does not? And sometimes it does not because you may be jet lagged or you have a shift work, right? The last factor you're talking about with poor sleep is presence of sleep disorders. It could be sleep apnea, it could be insomnia or restless leg syndrome. And all of these things, when you do not have good sleep quantity or quality, will cause problems in terms of your cardiometabolic health. So just like obesity, short sleep duration is common. And to figure out how common it is, a survey was conducted in a telephone-based survey was conducted in more than 400,000 adults. And they were asked a question related to how they slept or if they felt they had enough rest or sleep during the past 30 days. And to many people's surprise, only 30% or close to 30% individuals said that they never had an issue with that. And 11% said that they always had a problem every single day. about 17% individuals responded that it was pretty regular for them not to get enough sleep. And 41% agreed that this was a problem occasionally. So going forward, in 2014, this survey was again undertaken, and this sleep deprivation problem continues. This time around, close to 35% of the respondents in the survey said that they slept less than 7 hours each night. Now, here in this map, pay attention because there seems to be a close correlation with what you would see in obesity. The blue map here is telling you about sleep deprivation and how many people have insufficient sleep. This map over here with different hues of red or brown, whatever you call it, is telling you about the obesity rate. What is important is those geographic locations which are telling that these are the individuals living here who have poor sleep. These are the same individuals over here which have high obesity rates. This tells you that the obesity epidemic and the sleep deprivation may be actually interacting epidemics, or they might be feeding epidemics. That could be possible that poor sleep or short sleep is contributing to obesity, or who knows, obesity may be causing the poor sleep problems, right? So to further confirm, these are the findings from a meta-analysis of short sleep and obesity. And what they showed was that if you are poor sleep or had less sleep, the chances of you being obese were pretty high. There were actually 55% chance that you are going to be obese if you did not sleep more than 7 hours. We are interested in the visceral fat, right? So here we looked at what is happening with short sleep and adiposity measures. This is a study from the cubic family study, findings from the cubic family study, and they showed that individuals who slept less between 5 to 6 hours had a higher body weight, higher body adiposity, and waist circumference, which is suggestive of visceral fat. Now, during a 6-year follow-up period in the same short sleepers, what was found that the short sleepers had a greater increase in visceral fat and waist circumference both, suggesting that there is something in short sleepers that makes them gain more of a visceral fat. Now, visceral fat determined by waist circumference is not the best, but there is evidence showing that when you have actually identified visceral fat very well using a CT image, the same thing holds. If you sleep less, there is an increase in visceral fat area. On the other side, if sleep normalization is associated with lower adiposity gain. So this is again findings from the same cubic family study. And what they did was during the longitudinal follow-up period, they had seen individuals who increased the sleep or who maintained the short sleep. Now here, this is the data coming from the people who were in the control group who had good sleep levels to begin with. They found that there was an increase in BMI in all the 3 groups, but the increase in BMI was much more prominent in individuals who maintained the short sleep. This same thing was seen when they looked at the fat mass, but they did not see that much differences when they looked at the waist circumference. This suggested that when the short sleepers had increased their sleep, they kind of gained more fat, the lower body fat depots, which is kind of protective to cardiovascular risk, right? So these studies are all association studies. So we designed an experimental study. This was a randomized crossover study where each individuals were went through 2 experimental phases. It was a 21-day study with an acclimation phase, an experimental phase, and the recovery phase. During all these 3 phases, the food intake was ad libitum. They were allowed to eat whatever they want, whenever they want. What was happening though was we changed the sleep durations. In acclimation phase and in the recovery phase, we allowed them 9 hours in bed. However, in the experimental phase, they were either having a 9-hour sleep period or they had been randomized to 4 hours in bed. Each individual had participated in both the experimental conditions at 2 different time points. And our screening criteria was pretty simple. We just made sure that they are all healthy and they had a habitual sleep duration of 6 to 8 hours. During the 9-hour bedtime, they were sleeping from 10 p.m. to 7 a.m. And for 4-hour bedtime, they were sleeping from 12:30 to 4:30 a.m. So the point was that we wanted to make sure that the sleep point, midpoint is the same, minimize the circadian disruptions. Our primary endpoint in this study was the food intake and the changes in body composition. And the secondary endpoint was the ambulatory blood pressure. So what happened? Well, when a person was restricted, had a restricted sleep duration, they increased the calorie intake. All the data in red is from participants when they were in sleep restriction. And the data in gray is the data from when they were in normal 9-hour time in bed, right? So irrespective of the fact which group you belong, all individuals in the inpatient settings ate more because probably they had nothing else to do. But if you were in the sleep restriction group, the amount of food you ate was much more than what you ate otherwise. And these increases were coming from increases in protein intake, and a lot more was coming because of increase in fat intake. So what happened because of all these increased calorie intake? Well, there was a gain in weight. There was a gain in weight in both the sleep restriction and the control group. But the increase in weight was much more if you were in the sleep restriction group. Okay, so we saw that there was an increased calorie intake causing weight gain if you were restricting your sleep duration. Let's look at the regional body fat distributions now. So these are data coming from the abdominal CT images that we took over the study protocol. And as you can see, both the groups had weight gain. So both of them showed there were increases in the total adipose tissue area, but the increase, it's much higher in the red bars, which is from the sleep restriction time. There were also increases in the subcutaneous adipose tissue, and they were about the same in both the groups. But what was the most important thing that we found was that there seemed to be a preferential increase in the visceral adipose tissue only during the sleep restriction. So the gray bars here, they didn't really change much, but these red bars here, you see there was a good increases. And the important thing to look at here is this is fat. It doesn't just go away because you slept one day. It's there to stay. So this same protocol, we were looking at the blood pressure, and what we found was that sleep restriction is associated with sustained increases in blood pressure. But unlike the fat area and the visceral fat increases, during the recovery, when you were allowed to sleep, the blood pressure came down, which actually is a good thing, right? But that doesn't happen with fat. And interestingly, the mean arterial blood pressure in these studies was still associating very well with the abdominal visceral fat, suggesting that the visceral fat location is going to alter your blood pressure and increase the blood pressure if you were doing sleep restriction, and it's going to continue doing that even after recovery unless you have made efforts to lose weight. So to summarize, Sex hormones may contribute to regional fat distribution. Short sleep duration may increase calorie intake and contribute to weight gain. And lastly, short sleep may contribute to preferential increases in visceral fat. So this brings to the last part of my talk, which is what can we do to be healthy? This is going to be very short because we are all smart people and we know what we should be doing, right? So exercise, weight loss has proven benefits. It can prevent diabetes. In some cases, it can even remit diabetes, improve your glucose metabolism. It can reduce your blood pressure. It can even have effects on your mood, cognition, depression. It can reduce your sleep apnea. And if you are financially motivated, it will lower your healthcare utilization costs as well. What can we do? We should exercise. It is the best way to stay healthy. It will help you lose weight and also maintain weight, because you will gain weight if you don't care for yourself, especially if you gain age, right? Gaining years is not that hard. We should also have a controlled food intake, eat only when we are hungry. And an important thing to remember is that it's not just about what you eat, but also when you eat. Just like when you sleep is as important as how much you sleep. Lastly, I would like to emphasize sleep as a health investment. Typically, an adult needs at least 7 hours of sleep each night. And this will not just keep them healthy, but will also help them function optimally. There are several approaches to make sure you have enough sleep. Some of them are considered like a recovery approach, where you, for some reason, had a short sleep duration the night before, and then next day you try and make it up by increasing your sleep time duration. That can happen sometimes. Most of us end up doing what is called a catch-up sleep, where during the work day you are not sleeping enough, but you try and catch up on your sleep during the weekend. That also helps overcoming the sleep, the deficits that you have. There are several lifestyle interventions that you could think about. One would be to just try and increase your time in bed. That is helpful in many conditions, many cases. There are certain sleep hygiene practices that you need to take care of or be aware of so that you can improve your sleep. And lastly, there could be a combined approach where you are not just trying to extend your sleep, but also you're working on your sleep hygiene and you're trying to lose weight too. And that might be the best thing, but it's a hard thing to do. So what you should try and do is try and make sleep a priority. Do not reduce your sleep to make time for something else that you might want to do or need to do. In a survey in the American population, it was found that sleep is among the low things that people prioritize, and we really need to change that. To be able to get a good sleep, what we need to do is stick to a schedule, exercise during the day so that you can sleep better at night, create a nightly routine, decrease the use of electronics before sleep, and keep the room at a temperature between 60 to 67 so that you are nice and cool. And importantly, know when to seek help. If you are not able to sleep properly, it's a good idea to get help to fix that. So almost concluding, we have not been able to sleep, get people to exercise, but we are hoping that we might have a better luck in getting people to sleep. Let's see how far we can go with that. Now, to end my acknowledgements, the work presented here is all done when I was at Mayo Clinic, Rochester. And these are my mentors and colleagues, Dr. Somers, Dr. Jensen, and Dr. Kowasan. A lot of work that I've presented here has been done with them. And before I take questions, I would also like to tell you that I'm looking for postdoctoral students to join my research program. And now I am open to questions. Thank you.
Thank you.
Thank you so much. This was it was a lot of fun for me to follow what you're saying, because I've had my struggles with sleep, and I'm sure like a lot of people have had that as well. So it's nice to see scientists actually reinforcing that sleep is important, and that should be a primary objective. Just focus on that and everything else will follow. Oh, that's what I tell myself.
It will.
All right, so Dusty, do you want to go ahead and moderate the Q&A?
Yeah, thank you, Dr. Singh, for that talk. So I'm glad that I took notes on this, because my my Zoom cut out, and now that I'm back in here, all of the chat is gone. So I'm glad that I was writing these questions down. And when we get towards the end, if there are any questions that I am not reading because I maybe missed the last couple before my Zoom shut off, I apologize. We'll get to those. So the first question that I had noted was, when you assess obesity, do you use body fat percentage? And if so, what cutoffs do you use?
That's a very hard question to answer, because there are no guidelines available. You don't really know what classifications to use, but most of the time, many studies will say that if you're a man and you have more than 25% body fat, you are obese. And if you are a woman and you have more than 35% body fat, you are obese. But this is very investigator dependent. There are no real guidelines to tell you at what percentage you will be considered obese or not. So if you do research there and you try and publish, it's a hard thing to get through.
Okay, thank you. In your first study, the weight gain versus weight maintenance study, did you see a sex effect within the lower body fat storage individuals?
We did not have enough females in our study to be able to look at that. So we could not look at it with a reasonable confidence. So in short, no, we did not see that.
Okay, good to know. Yeah, there was one other question that also addressed that, like with that assumption, were females more protected in terms of increases in visceral adiposity, because females tend to have more lower body fat deposition.
That's what the epidemiological studies have showed us, and that's where the most evidence is coming from. People have tried to do studies where they try and get people from like upper body fat obesity and lower body fat obesity, but that's very difficult to do. Dr. Jensen at Mayo Clinic had decent success in trying to do some of those things. But here at Pennington, I know Dr. Rabison was trying to do, but it was very hard recruitment. But it's generally believed that that's something that makes a difference. And that's why females are protected. And when menopause happens, the estrogen is not helping you anymore. So you tend to start having more upper body adiposity rather than lower body adiposity.
I think along the lines of that, Dr. Padilla had a question about, did you see an effect of sex on weight gain induced impairments in FMD, or would you expect to if you had an appropriate sample size?
Potentially, right? If you had younger females, you would think that they would still have the protective effects from estrogen, and most of those women should technically be storing more fat in the lower body fat. And if you had that depot to take up the excess energy, then potentially you'll have less visceral fat and less impairments in cardiovascular function or blood pressure. But it's a hypothesis. We couldn't test it. There were not enough people.
Right, thank you. Could you stop sharing your screen so that we can just see everybody and
Yep.
you as well? Thank you. Okay, Dusty, next question.
Also, I was going to ask her, there was someone that had missed one of the points on the slide right before you started talking about sex differences. Dr. Singh, they were wanting to know what the third point on the slide was, and it started with among all fat depots. It was the
Yeah, so
slide
I was
just prior
comparing.
to the sex differences.
Yeah, so I was saying that if you're going to compare all the fat depots, my point was that if you think in terms of subcutaneous fat versus visceral fat, or upper body versus lower body fat, the fat among all these kind of differences, visceral fat is the one which confers the highest risk. That was the point there.
Okay, thank you. Dr. Dillon, I know you had put a pretty lengthy question in the chat about macronutrient breakdown of the diet. Would you like to reiterate that? Because I did not get all of the details of that one.
Right, so I was just wondering, if in that study of yours, if participants were, I missed the macronutrient breakdown of the diet, but if participants were put on a higher protein diet, and let's say the resistance training as well, and most during overfeeding, and the weight gain was mostly, let's say, lean body mass, would you still expect to see impairments in vascular function?
Previous studies, they have still been able to see detrimental effects, at least in the insulin sensitivities and stuff. I don't think there have been too many studies with vascular function, but I expect that if you have increases in lean mass as well, then the chances that impairment is as significant are less. So they would be like increases in muscle mass would take away some of the bad effects, right? But unfortunately for us, most of the time when we do gain weight, it's mostly because of the fat mass. I wish I could say that, oh, all I gained during my Thanksgiving is muscle, right?
Right. So it's just like an intentional weight gain that you see with, physique athletes and bodybuilders.
Yes.
And
Yeah, they don't really have detrimental effects. But again, if they try to reduce their fat mass to very unreasonable levels, then that is a problem. So what we found in that study was that the SHBG is actually related to the leptin levels. So it is kind of counterintuitive, because if you're trying to take testosterone supplements, say, to increase your muscle mass, that has an effect on your fat and it reduces the leptin levels. But what will also it will do is that it's going to increase the SHBG level. So the bioavailable testosterone would still be the same. So what you're doing has to be balanced. You can't think about reducing your fat so much that your body has nowhere to store it, excess calories, and it's a problem in metabolism then.
I think that goes to Dr. Veer Potter's question, a statement about sex hormones also affecting physical activity, as does sleep restriction. So what role do you think physical activity plays in those fat gain outcomes?
In our study, we deliberately tried to make sure that the participants did not change the physical activity. We did not really measure the activity levels, but we just told them. And the fact that none of them actually changed their lean mass suggested that they did follow our guidelines. But if you were to increase your physical activity levels, I would speculate that the detrimental effects would be much less, because muscle and the myokines play a very big role in trying to figure out how your fat is. Some cases, I think there are studies out there which also shows that it causes adipose tissue to become beige. So white is storing fat, beige can burn fat, and brown is like burns like crazy, right? So it provides a healthier adipose tissue if you can increase your physical activity through probably myokines and everything.
Okay, thank you. And we have one last question from Dr. Parks. Well, she says you've done a very nice job of showing which factors correlate with short sleep. It's known that, is it known what human characteristics lead to sleep deprivation?
There are several genetic factors which might contribute to shortened sleep duration. There could be medical conditions like insomnia, where it's not that you don't want to sleep, but you just can't sleep, which causes problems. But most of the time, what we are talking about is behavioral sleep deprivation, where we ourselves choose not to sleep. We might have too much work. We might have a small child who needs more attention. You might be a social butterfly. You like to party at night, or you always realize that your deadlines are right around the corner and you just can't afford to sleep, right? So we have all of these kind of conflicts with our life where we choose not to sleep. And those are the things which we would like to highlight and say, please make sleep your priority. And those are the things which we can change through interventions, like at least non-pharmacological interventions to help out.
Thank you. Well, thank you so much for such a great talk. And everybody, if you could just unmute your mics and give Dr. Singh a round of applause.
Thank you for having me. I really
Thank you.
appreciate
We
this.
only wish that we could have had you over in person.
Next time, hopefully. Right?
Yes, yes, for sure, when you come over. Well, thank you so much, and it was really nice meeting you.
Okay, bye.
Bye.
Yes,
Bye.
thank you so much.
Thank you.
Like a year late or a year and a half after you were scheduled to give seminar.
Yeah, it was supposed to be March or something like that, right? But better late than never.
Oh, well, thank you. The data are beautiful. I appreciate you sharing.
Yeah,
Thank
and
you.
if you want to send like a short blurb about the postdoc position, like what exactly you're looking for and the research area, so we could circulate it amongst the grad students here and on Twitter.
Awesome. That'll be great. I'll work on that and get you something.
Thank you.
Bye.
Have a good rest of your day.
Bye.